looking for is we're inspecting for symmetry, swelling, atrophy, and deformity from the hips. Okay, we're looking at the hips. We're looking down the legs as well. People with, pain within the hips. People with a leg length discrepancy may be tilted one way or the other. Okay, so that's what we're looking for. And then I'll have you come back and kind of turn around toward me. And then we're going to inspect and palpate the lower extremities for temperature, hair distribution, color, texture, thickening, and tenderness. We kind of did that with vascular, but making sure we're going down the legs, making sure we have good hair distribution. If we don't have good hair distribution, what are we thinking? What are our thoughts? No blood flow. Peripheral vascular disease type thing, okay? Different color, making sure we have good temperature, making sure we don't have like an ischemic clot one side or the other. And then we're going to assess for edema. I'm going to have you sit because we're going to go there. But we're on the PowerPoint, it talks about assessing for edema, being able to document 1+, 2+, 3+, 4+ edema based on how much swelling and how much pitting is going on. So take a peek, review that as well. And then inspecting and palpating the lower extremities for varicose veins. Okay, so you can inspect, look over them all. And then if we do have like a patient, a true patient, we're going to be looking up into the groin all the way up into the outside of the hips too. Okay, and then I'm going to have you lay back and then slide yourself back. Okay, so now we're going to palpate the hips and pelvis for instability or tenderness. Okay, so we're going to push on the hips. Remember, a lot of the hip is in the groin area. Okay, we kind of talked about that. If someone's complaining of hip pain, making sure we really differentiate between if that's groin or if that's lateral hip. A lot of lateral hip is in the back. A lot of true hip pathology is in the groin. Okay, and so we're palpating the lateral aspect up into the groin and seeing if that has any pain on the hips. And then to check for instability, we're going to do what we call a compression test. We're going to push in from both sides and down. Okay, and so when we're checking for hip stability, we're going to go in and down. We shouldn't have any crepitus. We shouldn't have any, but if we have a pelvic fracture, a trauma, we're going to have some instability. It's going to have a lot of significant pain. So we're compressing in and down on that pelvis. Okay, and then my kid is at school sick. I just sent him with Tylenol. So, some may be getting a phone call. Okay, so differentiating between active range of motion, passive range of motion. Passive range of motion is what we're doing to the patient. Active range of motion is what the patient's doing themselves. So we're going to do active range of motion for the hips. So we have to remember flexion of the hip is narrowing that angle. So first one we're going to do is we're going to have the knee flexed, okay? And now you just drive that knee up to your nose. There we go. That's hip flexion with the knee bent, okay? Now straighten it out and then do the same thing. Lift that, kind of bring your toes to your nose and lift that leg straight up. There you go. There's hip flexion with a straight leg, okay? And then we're going to go external rotation with the hip. So there we go. Now I want you to drop that knee out. There we go. There's external rotation. Okay. And then same thing, drop that knee across. There's internal rotation. Okay. A little tight and stretch. Okay. So we got internal rotation and then abduction, going out this way. Good. And then adduction going across midline. There you go. Good work. So there's active range of motion on that. Okay, so now we're going to do Patrick's test, where we're going to have him bring it over here. And then I'm going to push down on the knee. Okay, hopefully a negative is not eliciting any pain on that. And then the straight leg test is we're going to lift the leg up for him and see if we get any nerve root compression in the lower back. Okay, so if they're having any pain, we're going to again do them all bilaterally. I'm just demonstrating on one side now. Okay, so there's the straight leg raise. If we're getting, I think the technical on this is we get to about 60 degrees. So if this is 90, If we get to about 60 degrees and they're having pain, that's a positive test, okay? And then we're gonna do flexion, abduction, and adduction against resistance. So you can have them bend and then flex. There you go, okay, good. And then I'm gonna have you go out this way, good, okay? And then same thing going in, adduction. That's how my dragon that I train, I spell it out, abduction, I say it that way, versus adduction to get it pronounced right. Okay, so we're gonna flip you over on your prone, go on your stomach. This test has a lot of flipping back and forth, standing up and down. Just, you can, if you wanna try to finagle it the way you make sense in your brain and just get all the points, I'm fine with that. But it is a lot of flipping back and forth, standing up and down. Okay, so now we're going into hip extension. Okay, so I want you to try to raise your leg up. There you go. There's hip extension. We're getting a bigger angle on the front. We're widening that angle on the front of the hip. Okay, now we're going to do that against resistance. Good. Put it down. Other one. There's okay. And then we're going to palpate on the trochanteric bursa if there's any pain or swelling on either side. Okay. Okay, now we're going to, I'm gonna have you slide to the end and stand up. You're good with, so we're done with hip. We're gonna go to knee. And we're gonna palpate. Okay, I'll just have you turn around for this. I just show. We're gonna palpate, keep turning, there you go. We're gonna palpate in the back, the popliteal fossa, for any tenderness or swelling, okay? What's a potential cyst that we might see that's swollen or painful in the back of the knee? Baker's. There you go, Baker's cyst. Good. Okay. Have you lay back down, supine. We can do that one, just thinking about that, we can do that one this way as well if we want to just keep them laying supine, as we can palpate the back of the knee that way. Okay. A lot of our patients will be in bed anyways. Okay, so now we're gonna inspect the knee extended. So making sure that we're fully extended for symmetry, swelling, atrophy, deformity, and leg alignment. Okay, angle between the femur and the tibia should be about 15 degrees. Okay, that's where we went down here, and then we measured there up, so we have a not a wider than 15 degrees into here. Okay, then we're going to palpate the patella. So we first looked at the entire knee, making sure there's not any swelling. A lot of people have swelling up in the top of the knee, the prepatella bursa. Okay, if we're having more knee swelling and knee effusion, they're going to be swollen more along the joint. Okay, the joint line. But a lot of times they'll have a swelling up here. We'll see people that are on, wrestlers, athletes that fall and bump their knee. Or they're on their knees a lot. We'll have the prepatellar bursa that's swollen. So looking, identifying that. If we get a good arthritis, a good medial or lateral compartment arthritis, they'll have a lot more kind of bony abnormality prominence on either the medial or lateral side, depending upon where they're wearing out the most. Okay. So now we're going to come in. We're going to palpate the patella, make sure it's movable. Okay. And then we're going to palpate the patella tendon, make sure that's intact. And then we're going to palpate the tibial tubercle. Okay. And then we're going to palpate the medial and lateral tibial femoral joint spaces. Sometimes the easiest way is if you have to bend them a little bit to find where they're at. And then you can straighten them out again. And we're going to palpate down that medial joint line. We'll palpate down that lateral joint line. Okay, and then we'll palpate the medial and lateral collateral ligaments, making sure that there's not sore, not painful on the outside. Okay. And then we're going to do kind of the same thing. We're going to flex the knee. So I'm going to have you just bend the knee, good. Kind of bend it as far as you can go, good. And then fully extend it. And then when it talks about hyperextension, you almost have them try to flex their quad and pick their toes up to see how much hyperextension they can get, okay? If the patient can't physically do that, you can just grab their toes and just hold up their toes and try to get them to relax to see if their knee can hyperextend. Okay, now we're going to do muscle strength against resistance with flexion and extension. The easiest way to do that is bend this and then have them so you can try to kick me, try to move out, good, okay, and then try to curl it back. There we go. There's flexion and extension against resistance. All right, we're going to move into the special tests of the knees, okay? We're going to do, the first one is going to be McMurray's. I'm going to come over on this side. We're going to bend the knee up, okay? And we're going to put our hand on top, okay? I think I talked about this in the lecture, but the easiest way to remember this is the side that I'm exposing. So when I go to medial McMurray's, I'm exposing the medial side, so that's the ligament, or the meniscus I'm looking at, okay? So I'm going to bend them up, I'm going to externally rotate them, and then I'm going to bring them through full range of motion with my finger on the joint line. I should potentially feel clicking or popping if they have any kind of meniscus injury or pathology. Now for getting the lateral, I'm going to rotate them, internally rotate them, and go all the way through full flexion out to extension. And you'll go back and forth through that maneuver. Okay? And they should say if there's any pain with that. Why we want you to do these bilaterally is because it's a little bit difficult. More if you're certain hand dominant, we're going to internally rotate them. Ooh. Gotta quit playing balling. Okay, now rotate it again, and it's all about hand placement and getting them fully flexed and rotating them through while keeping your hand on that joint line. Okay, so that's McMurray's. And then anterior and posterior drawer. So anterior, we're going to set them up, foot there. So on the anterior test, if we do the anterior test and we're just going to pull, if we have a more slippery surface, the foot a lot of times goes like this. This is also the cheating way to do a check for an ACL. So we're going to sit on the foot. We're going to put our hands right. We're going to stabilize the tibia, and we're going to try to anterior translate that tibia forward. If they have a good ACL, they shouldn't have any okay? So I'm preventing the foot from sliding forward, and I'm trying to what I'm trying to do is get this tibia to go here, okay? And then on the posterior aspect, we're going to do the same thing. We're just going to push back on the tibia, okay? So there's anterior and posterior drawer. And then Lockman's. So Lockman's is for what? ACL. This one's a hard one, okay? Just trying to get the patient to relax is important. So you kind of have to coach them to try to relax the quad. And what we're going to do is we're going to try to do the same concept as the anterior drawer. We're going to try to get that anterior translation of the tibia. And so what we're going to try to do is we're going to try to push a little bit down on the femur or stabilize the femur while bringing the tibia anteriorly. And so he's got good. I'm trying to pull straight up on the tibia and trying to push down on the femur, on the quad. Now, if you can think about someone like a 6'6", 350-pound lineman, it's hard to do this test, and then you got to switch hands on this one. So I want you guys to try to practice. Honestly, try to practice on a guy like Andrew, okay? Just trying to use that just as a size perspective on a leg, okay? So that's Lockman's. And then we're going to go to Varus to test for lateral collateral ligament. So ultimately what we're going to do is we're going to try to push and stress the lateral collateral. Okay? So we're going to hold at the bottom, and we're going to try to open up and push the knee out this way to try to open up that lateral collateral ligament. Okay, we'll do it this way. So I'm gonna kind of pull in the foot midline and push out on the medial aspect. I'm trying to get that tibia to shift outward. And why it's, again, good to do these bilaterally is if someone's complaining of like an LCL injury to the left, I want to check the right first to see how much laxity it has. If it doesn't have any laxity, and then we go to this one, and if you have a good patient with a good LCL injury, MCL, you'll feel how much it moves. Okay, so there's varus for lateral collateral. Then we're going to go to a valgus. We're testing for medial collateral, same thing. Okay, and then the second part of that, so that's at the 0 degrees. Now we're going to drop it off the table and go to about 30 degrees of flexion and do the same thing. We're trying to just get a little bit higher up on that MCL. Okay. So there's valgus and varus stress testing. We went through McMurray's. And then what I'm going to have you do is I'm going to have you sit up, slip your shoes and socks off, and I'm going to get some gloves because I don't touch feet without can I steal a stool? Okay, I'm going to have you quick stand down, stand on the ground. So we're going to inspect his feet for the longitudinal arch for abnormalities, pes cavus or pes planus, flat feet, high arch feet. Just taking a peek at what you think, okay? And then this one's a little bit hard to do here. It's sometimes painful on the knees, so what I'm gonna have you do is I'm gonna have you lay on your stomach on the bed, and I'll kind of show you a modified Thompson's to test for Achilles. So you can palpate the Achilles to just see if it's intact, or we can just squeeze the calf and watch that foot move, okay? I kind of realized last year that having people kneel on that little stool on the front of the pull-out bench on those chairs or those tables up there hurts, so you can just do it this way, okay? So Achilles is intact. If we don't get that plantar flexion, then we have to be really suspicious of an Achilles tendon rupture, okay? I'm going to have you now flip over and then sit up. Slide up on the edge. Okay. All right, now we're going to inspect for any swelling, symmetry, deformity, or atrophy, and then we're going to palpate that Achilles. Okay, palpate the Achilles, palpate the lateral mal, the medial malleolus. Okay, palpate the tibial talar joint. Know that that's a three-dimensional object, so it goes all the way around. And then we're going to palpate the metatarsal phalangeal joints all the way down the foot. I find it easiest to just follow each one, like 5th, 4th, 3rd, 2nd, and 1st. Okay? And now we're going to do active range of motion of plantar flexion. So I want you to point your feet down, okay? Point them back up, dorsiflexion, and then we're going to have them go inversion, eversion, and then flexion of the curl of your toes, and then extend your toes. Good, okay? And now we're going to do these, and these are where you can do these bilaterally with your hands. As you can say, I'm going to push down, good. Now pull back up, good. Now flex your big toe, okay, and extend your big toe, okay? So there's assessing for muscle strength against resistance. And then on the talar tilt test and the anterior drawer, this one's a little bit tough, so we can kind of walk around. So on the talar tilt test, we're testing the ligaments on the lateral aspect of the, I'll go over here so you can see them. Mm-hmm. Okay, so we're gonna put it first at neutral, and then we're gonna invert the foot. Okay, now we're going to go up and we're going to invert the foot, and then we're going to put them in full dorsiflexion and invert the foot. So we're trying to work our way around that whole lateral aspect of the ligaments. If he doesn't have any instability, But if you're concerned with like an ankle sprain, that is the ligaments that we're going to be looking at that have some laxity in them. Okay, and then the anterior drawer we're going to do is very similar to the Lockman's. Is we're going to grab the heel and we're going to try to bring the ankle forward with the calcaneal pressure, seeing if we have any looseness, trying to get that going forward as well. So that is the anterior drawer of the ankle. If there's some laxity in there, you're concerned with like an ankle sprain as well. Okay? Questions on the musculoskeletal physical exam?
Can you do the last one bilaterally?
Yeah.
See it on this side?
Okay. So anterior drawer, we're going to hold here, and we're going to try to pull this whole foot forward. Okay? So we're trying to stabilize the tibia and pulling that whole foot forward. And then on the talar tilt, we're going to go at just here, we're going to invert, and then we're going to go up to neutral and invert, and then we're going to go all the way up to dorsiflexed and invert. Okay, so 3 different locations. Okay, questions on that? Page will be down here. I'll be up in the rooms. But if I want...
We're on 7%.